Hello, everyone, and welcome to Schmidt List. I am your host, Kurt Schmidt. I am so excited for today's show. I am really glad that you are here, too. I am launching another additional podcast soon. You'll be able to check that out. It'll be on YouTube. It's going to be called Agency Unfiltered, and it's going to be really aimed at people in the professional services space, in digital marketing, IT services, all sorts of things like that. So I'm really excited. I'm going to be launching a new show. It's the first one. I've been doing this show now for 7 years. So having a new show, it's going to be a lot of fun. I'm going to have some fun with it. But don't worry, this one's going to keep going. So, I'll still be around. Before we get started, I do want to mention the Little Book of Networking is available this side on Amazon, and it's getting tons of great reviews. So make sure you go in and check it out. I'm really proud of this book, and it seems to be more valuable than ever, especially post-pandemic. So, all right, let's jump in and meet my guest, Dr. Doug. Dr. Doug, how are you today?
Hi, great, Kurt.
I am so excited you're here. Tell me about what you do and who you do it with.
Yeah, well, it's just great timing. And I want to tell the audience how much I appreciate your book. I've learned so much just in the last year or so going through my journey. So I'm a transplant surgeon by training, liver, kidney, pancreas, and I've been a chair of surgery at a couple different institutions. I started networking and thinking about a career change about 1.5 years. I took a little sabbatical. I too wrote a book called The Process Manifesto, Improving Healthcare in a Complex World. And that really led me to think about how can I actually bring value and do my part to help change healthcare, to help improve access, to help improve outcomes. So I just started a new position at the Belmont University Frist College of Medicine, brand new medical school here in Nashville. We get our first class of students starting in just 2 weeks, so very excited about that. At my job, so I'm a professor and chair of health system science. And what I'm doing here is creating a center for health system science. You say, well, what is that? Well, health system science is really this umbrella that aims to learn more about the systems in which we deliver care. So everything from payment models to communities to social determinants of health, how healthcare professionals and patients, importantly, actually function within the system. And in creating this, first of all, this career journey sort of slight change here, getting out of the operating room and into this health systems world, has really led me to, I'll be honest, get out of my comfort zone a little bit and start networking with a huge variety of people, from private equity and venture capitalists to startups to community. Really, my goal is to get thought leaders and stakeholders together in basically a think tank. That's what the center will be, a place to study, to innovate, to transform healthcare in a scalable, sustainable way that really improves, hopefully, care for a lot of people across the country.
Yeah, I think it's noble work, and I'm really impressed by the amount of change you've gone through in such a short amount of time. It's pretty powerful. Well, and I want to talk about this health systems stuff because some people might be listening and saying, well, I don't really work in the healthcare space and it seems very complex and all these things. But I mean, at the core of everything that's you're working on, this is a people thing. This is a person thing, right? And so a lot of change management probably has to come into what you're doing, right?
Yes, it's all about people as capital, whether you're an employee working in healthcare, so a physician, a nurse, or administrator. So that's sort of the capital of the system. But then you also have this capital of patients as consumers. One of the things that's really sort of poignant that really got me thinking as I wrote my book, we always have to have your list of things for people to follow, your sort of recipe. So I have 10 in my book, and I shared my ideas with a lot of people. the part of this networking. And everyone from patients I had operated on to people who are really thinking about compassion and empathy, they told me that I really needed to include compassion because whenever I spoke to people about healthcare, that was one of the topics I always brought up. And as I thought about compassion, I really reflected on this and I realized that in a healthcare, so often we create this us versus them dichotomy, the health system versus me, the insurance company versus the doctor, the hospital, or the patient. But in reality, at some point in our lives, every one of us is a caregiver and every one of us is a patient. It's just an inevitable aspect of human existence. So one of the things I'm really excited about conveying and part of this change management is to try to break down this. We have this us versus them concept and to realize, at least at a societal level, we're all in this together.
Yeah, right. Well, and I think it sounds like a lot of education has to go into that, right? I mean, it isn't something where you can just hope that the processes will solve the issues for you, right? You set these frameworks in place and you just assume and hope that everybody will follow them. Because, if we look in most recent news, Amazon and their One Medical just had a big blow up where certain situations weren't escalated the way they should have been at One Medical. And so it caused a lot of issues. And so back to your point about making sure you've got great processes in places is fine because they had the processes in place, but people just didn't seem to follow them in certain cases, right? So to get back to what we were talking about here, it is really about making sure that people understand the value of these processes and frameworks that we're putting in place. Not just education, right? Like there's got to be some empathy and compassion that go along with it, right?
Well, yeah, that's absolutely right. And I think it's a couple of different aspects to this that I think you alluded to, that they're all interconnected. So one is education and training. That's incredibly important, both on the professional side and then on the patient side. If you look at patient experience, one of the things that comes up over and over again is they don't feel they were educated about medications or discharge. So education and training, super important. And then the next thing is really thinking about how do we align resources with need? And so, one of the challenges with the Amazon One Medical, as you pointed out, was that sometimes things didn't get escalated. And the way I look at that is the processes are not consistently identifying what resources need to be put together with a specific patient. And that's where social determinants of health, what I like to call the context of health, so environment, family support, transportation, social, cultural realities of the individuals, they all make a huge difference. And then the third component is really important. And I'm super excited because I think we're at a transformative period where we have lots of data in healthcare, but we've had a really difficult time moving that data into what I like to think of as actionable information. What we really need to optimize human performance is to translate that into information, which is actionable at the point of care delivery.
Well, it's interesting because you mentioned we're at this point, but there is something to the going, again, I don't want to harp on the One Medical thing, but I want to ask you, Doug, is there process problems or are there leadership problems that need to be really focused on? Because I feel that with the appropriate leadership in some of these areas, the processes sort of just kind of work themselves out if you have a strong leadership. And I don't mean just bosses, right? I mean everybody all across the system itself. how does leadership play into the work that you're doing?
Well, leadership you're absolutely right. It's a huge component of it. And one of the challenges, and I argue this in my book, one of the challenges is that healthcare is really complex system or series of systems. So we have to think about, how do we manage complexity? Unfortunately, our traditional training, both for physicians and many people that go into healthcare administration, they're uncomfortable with managing complexity. So what do you do in response as a human being? You try to reduce things to a very linear structure, which you think is understandable, kind of like an assembly line.
Right.
Well, we have to have standards, but we realize that human beings don't react like a car on an assembly line, We all come with individual needs, and things happen at 2 a.m. I mean, if you've had children, you all know they get a fever and get sick at 2 a.m.
They do. And they love getting an ear infection at midnight.
Yeah. And so the key here as part of leadership is to determine ways to empower people on the front lines of care to really be effective. One of the strategies that I love is called adhocracy. And adhocracy is really, in many ways, the opposite of bureaucracy. Interestingly, the term evolved largely after President Kennedy made the challenge to put a man on the moon. And when you think about it, NASA had 2 leadership strategies they could have used. One was a very hierarchical structure where everyone had specific identified tasks and accountability. And they realized that that was self-limiting. So what they did was they brought in experts, they applied the resources that the experts needed, and then they let the experts complete the task. So in other words, they empowered people on the front lines. Now, clearly, you need leadership to say, well, we need quality. This is our timeline. These are our objectives. These are the measurables. So I'm not saying leadership ceases to exist. It's not anarchy, but it's really leadership that embraces the idea of empowering others to multiply their effectiveness, to really optimize human performance at the end of the day.
Yeah, and I find that that's what's somewhat lacking in some of the leadership that I see. It's people that can set a vision, explain why the vision is important and what the value of that vision is, and then guide everybody to work towards it. But to your point, more run, block, and tackle so they can get there, like get things out of their way to make sure that they can make it there.
Right, exactly. And then if you think about that in terms of processes, then it really helps leaders and managers make sure that the key performance indicators and the expectations of the outcome of the process really work. One of the challenges we have, if we go back to that reductionist theory, that, assembly line theory, is that too often the key performance indicators are focused on aspects of the process itself rather than the outcome. So in healthcare, what would that mean? Well, our process measure might be, for everyone who has a knee surgery, we want them out of the hospital in less than 24 hours. And you say, okay, fine, we can do that, but is that right for every single patient? And should the key performance indicator, the ultimate outcome, really be, are the patient's knee surgeries successful? Are they ambulating? How many are coming back with infection, need replacement? And then the other aspect of that, which is admittedly challenging in healthcare right now, is that our payment models often have perverse incentives where sometimes you make more money with a complication than you do with an uncomplicated outcome. Now, I'm not saying that anyone is nefariously sitting in their office saying, oh, I hope Dr. Slakey has a bad outcome, on his surgery.
Right.
None of us want that. But at the end of the day, when you're looking at the finances, you build into the financial projections as your payment model that revenue from adverse outcomes. And so what does that do if you're looking at quality improvement, if you're looking at aligning resources with patient need? It's very hard to ascribe profitability or return on investment to some of those decisions. And we need to change that.
Yeah, that sounds, I guess, how a Target or Walmart would just have acceptable losses from stealing and right instead of, I had a boss, one of my early college jobs that just paid people terribly to work at a retail store. And his argument is like, most people steal from me, so I'll just pay them less. And I was like, well, you could pay them more and they won't steal. And he's like, it's actually cheaper if they steal stuff.
Yeah, well, that philosophy is probably all too common,
Yeah. Well, but again, going back to leadership styles, if we look at, sort of the Jack Welchian era, the command and control sort of corporation, it seemed that, healthcare followed a lot of that sort of space for quite a long time.
Yeah, I think you're right. And there are definitely industries where that makes sense. So sort of the Toyota way, the Lean or Six Sigma theories. And there are elements of that certainly are translatable to healthcare. Check-in procedures, check-out procedures, those sorts of things which are highly routine, standardized. I have no argument with those at all. But where I find a challenge is that leaders often don't really appreciate how much, they acknowledge it, but they don't really appreciate how much we spend on training, education and training. And furthermore, how valuable that is. We talk in healthcare a lot about lifelong learning as a goal. One of the primary goals that we talk about in medical school and resident education, the amount of time and money that we actually invest into continuing education continues to fall dramatically. And I see that as a challenge because we have to, again, going back to that idea of employees as an asset, not purely a cost on the balance sheet. We have to think of our people as assets. And if we think in terms of that, acknowledging it's a lot of money to employ people in a hospital, no question about it.
Yep.
But they really are an asset. And we have to think about, okay, if we have that asset, how can we as leaders and managers optimize the performance, the return on investment that we make into that, instead of thinking, well, if it becomes too expensive, we'll just let people go. And what happens, unfortunately, is sometimes we cut until we realize that we can't provide the care we want to.
Right.
And then we have to build it back up.
It's a cycle, right? Well, and you see it when new leaders come in too, right? Because they'll want to make a big impact. So cut to show the bottom line is coming up. And then all of a sudden, to your point, like the quality goes down and then they're gone and the new person comes in and the same cycle starts to continue. Well, to that point, Doug, I want to ask you this idea of education. There's a hard balance for some employers where regardless of healthcare, and I want to get your advice on this, is that I need people working with patients. I don't need people out taking classes. And that's where I'm getting my money, is by billing. So how do I balance this? What mindset should I have as a leader that's trying to balance this bottom line?
Yeah, well, I think there's a couple of really important take-home points here. One is that within a large organization, if you stop thinking in terms of silos and you think horizontally across the organization. So what I mean is not by department, not by specialty, but think about care teams. There's a tremendous opportunity to share best practices, to share experience, to share, whether it's anecdotal or more evidence-based, but to have this generative learning as part of the culture. And that really gets to culture change. It's so important to move from a philosophy of blame. In surgery, we used to say the ABCs of surgery: assess, blame, and criticize. That was, and really what we need to do is take these as educational opportunities. And it's hard for people, but I'll give you one example that was so poignant to me. We were right after COVID, when I was in Chicago after the pandemic, we were, of course, scrutinizing infections in the ICU. And the usual thing, everyone said, oh, people aren't washing their hands. Maybe there's truth to that. They aren't changing their gowns and gloves appropriately. We need to educate, or we need to penalize. There was a lot of talk about penalizing people, secret observers. Well, we brought into the team environmental services, so the people who clean the room. I'll never forget this. One person was sitting very quietly in the corner. I could tell they wanted to say something. So I asked them, and they said, well, gee, Dr. Slakey, do you realize that those mattresses on the ICU beds weigh 60, 70, 80 pounds? We've cut the staff so that only one person cleans the room, and we can't lift those mattresses to clean under them. So we all walked up to the ICU, found an empty room.
You're my couch right now, Doug.
Yeah, well, it was a great example because none of us had even remotely thought about that as a potential problem. And so we changed the process. We got more people to help lift the mattress, do a thorough cleaning, as opposed to sort of a cursory wipe down of the accessible services. So I think that's a really great example. The other thing, which I'm super excited about and have devoted a lot of my career to, is simulation training. So how do we take people and not just train them to do something, but instead focus on additional training? How do they respond to the unexpected? Now, the airline industry, Department of Defense, they do a pretty good job with this, but in healthcare, we really haven't done that. It's a challenging environment for high-performing professionals to look at situations, to be put in situations, and then to have to reflect on, what did I do wrong? What did we do wrong as a team? What could we have done better? But really important. And when you think about it, there's a lot of space in hospitals where you can cobble together simulation. It doesn't have to be super high fidelity. It can be, something which is very tangible. I'll tell you one of the things that I'm really excited about, our brand new medical school building here in Nashville. We have 2 entire floors of simulation.
Wow.
So not only can we educate students and residents and nurses, et cetera, but we can bring technology, processes, new ideas into the simulation environment, actually test them to see how human beings respond to them. How do they perform? And this is just something which is,
I think it's
really
super powerful. I think it's super powerful because, it seems like, and you tell me if I'm wrong here, but even in the technology space, I've been a part of for 20, 25 years, people are niching down and specializing more so. And to your point, it sounds like even in the healthcare industry, that people are doing the same, but then that means that they don't work together as often as partners on things that have adjacent or direct correlation to each other. And so if you can simulate them being able to work together around certain parameters, it sounds like that would be a very powerful impact.
Yeah, I think so. And I think even technologies like remote patient monitoring, hospital at home, they're great ideas, but they tend to be implemented, and maybe I don't know enough about One Medical, but they tend to be implemented without really being tested, right? We sort of test
Right.
them on the fly, as it were.
Or we model them, right? We model them on paper or in a computer, but not actual human beings.
That's exactly right. And, we get alarm overload, we get fatigue, all these different elements that human factors experts, leadership experts, communication experts, they all know, and even practically we all know the way that technology can impact us for positive or negative. But when it's human lives at stake, I really think that one of the exciting things we can do in the future is to really test these technologies and let's see how they actually work. And to your point, Kurt, let's get the tech people out of their offices. Let's get the physicians and the nurses and administrators and put them all together in these environments. And I'll give you one more quick example of how powerful simulation is. So I used to do a lot of I've done almost 1,000 kidney transplants. And one aspect of kidney failure is dialysis. So you hook up an artery and a vein in the arm. That's called a fistula. It wasn't that long ago that those of us who were surgeons were recommending that dialysis centers use ultrasound to put these pretty large needles into the fistula, because as surgeons, we would see complications when the needles weren't put in correctly. So we did this simulation, and it was really eye-opening. We gave a lecture, then we went the simulation. It had a simulated fistula, which was pressurized. It would bleed. And we actually mixed surgeons, technologists, nurses, and administrators. And the amazing thing was we would have everyone try to stick the needle into the fistula without an ultrasound. And then we would do it with the ultrasound. And guess what happened? The administrators in the debrief afterwards, they all said, we are going to buy ultrasounds, because they had a hard time putting the needle in without it. But with it, even an administrator was able to be very successful. And so it was an eye-opener to them. They used to look at this ultrasound as just a cost. But then they realized, wow, this is a human quality of care issue, and it's gonna make the outcomes better. So that's just, I think, a really great example of how it changes the leadership mentality, and it goes back to that idea of what is the leadership's consequence of getting the ultrasound. They're actually empowering the professionals on the front line to do their job better.
Yeah. It's a leadership thing, because I've been a part of larger changes with that and trying to get leadership to participate in those types of simulations. We've done lots of hackathons, for example, in the technology space, and trying to get leadership to join. And they're like, well, I'm very busy. But to your point, every time I've seen them, you get a C-suite type executive on a team with other people, it could change the whole dynamic of the company.
Yes. Yeah, it really can. And I think it just improves communication. It improves, going back to empathy and even compassion, right? We're really talking about human beings and human suffering, and how can compassionately motivated leadership decisions actually change human suffering. And I think most of us, when we realize that that's something we can actually be part of, it's very powerful.
Yeah, well, and to your point, you've got to have the right people that have that compassion, have that empathy to understand the value in those situations, because, and I've seen it before, where I'm working with executives and they're telling me about what the customer needs. And I'm sure you've had administrators telling you about what the patients need. It's like, when was the last time you talked to a patient? Like, when was the last time you talked to a customer? It's probably been a very long time, right? You're probably anecdotally pulling a lot of stuff out of spreadsheets you look at.
Well, right. Or, they do the leadership rounds, which always bothered me. So, everybody's busy, and then you see 3 people dressed up in suits.
Yeah, and now you got to look busy.
Right. I better look busy, and I'm only going to take you to the patients who are going to say everything's great.
You're right. Yeah. Yep. Exactly. Yep. No, that's definitely happened to me during one of our pregnancies. It was a lot of fun, but I think it was about 9 people that showed up.
Yeah. An intimidating group.
It was a very large, intimidating group of very serious people. So, Doug, I could talk to you all day, but we do need to cut it short. So one last question I have for you. If you were to give advice to someone that is trying to get buy-in to these new ideas and doing these things, where is a great place to start? Like, where should you've got this great idea, you think other people would benefit from it. What's worked for you? Where do you start to make that change happen?
Yeah, I think the most important thing is really being able to articulate a vision, an outcome in a concise, meaningful way. I think that's, it's the
right, not just change for the sake of change.
Right, exactly. And, so often we fall victim of focusing on how are we going to do it or what. And sometimes that leads us to this proverbially putting out fires all the time. And so we have to step back and think, okay, on a broader scale, why are we doing something? And then the other super important thing is that you have to be willing to listen to dissenting voices, right? To people who have different perspectives, because what we do a lot of times as leaders is we come into a situation and we have a sort of our conformational bias where I've created my vision. Here's my bias about why it's good or why it's bad. And so I'm just going to find people who agree with me and confirm my own pre-existing bias, even if I don't admit it, even if I think I'm doing something very holistic. So seeking out those consenting voices and actually being quiet and listening to them and getting them to contribute. And then the third thing, and I think it's interrelated, is as a leader or a manager, really thinking through all of the people who are connected with the process. So I like to think in terms of the patient's healthcare journey. So often, especially healthcare is a great example of where we sometimes look at a snapshot in time. Like I go to the doctor's office and I get my blood pressure checked twice a year. And that snapshot in time is presumed to be reflective of the other 363 days of the year, right?
Yep.
You have to look at this whole patient journey. You have to understand, what are all of the elements, the people, the context that really are impacting that journey. So those are kind of the 3 elements I think that are really critical to reflect on and to be serious about as a leader when you're commencing this meaningful change and process reevaluation and improvement.
I love that. I think those are strong things to think about because, again, not just in healthcare, but in a lot of aspects of our world, we could use some more people listening to dissenting voices with an open heart and an open ear.
Without becoming defensive and argumentative, because if those voices exist, there's reality that they are seeing that others of us might not be experiencing or seeing for one reason or another. So we have to figure out how to appreciate that and incorporate it into change which is meaningful and sustainable.
That's great. Well, speaking of appreciation, I appreciate you, Doug. Thank you for taking the time to join me. So tell me about where I can get the book. And if I want to follow the work that you're doing, where can I do that?
Yeah, well, thanks so much. So, yes, the Process Manifesto, Improving Healthcare in a Complex World, and it's on Amazon, and then you can get it at all the major booksellers around the country. I do have a website, processhealthconsulting.com, which has some updated information about what I'm doing. And then people can find me now at my new home at Belmont University Frist College of Medicine here in beautiful Nashville.
That's so great. Well, Doug, thanks for taking the time to join me. We'll have to have you back on as things progress. I'd love to hear all the learnings that you're going to find while you're doing the work that you do.
Yeah, well, thank you so much. It's really been a pleasure speaking with you, and I appreciate it.
Thanks, Doug. All right, everyone. Thanks for taking the time to join me and Doug today. I appreciate you for joining us. I've got the book, Amazon, and you can check out Doug's book on Amazon. You'll see links below. I'll have links to Doug's book, so make sure you check it out. Thanks very much for taking the time out of your week, and we'll see you next time.